Good evening. Welcome to ASA COVID-19 Town Hall webinar for April 2nd, 2020. I'm Sarah Solomon Dodden. I'll be your host for today. Tonight, we are grateful to have anesthesiologists from New York speak for the first half of the discussion. In the second half, we'll discuss financial considerations for anesthesia practices from leaders of our anesthesia administrators and executives, as well as staff from ASA's congressional and political affairs and payment and practice management departments. Before we begin, a message from the lawyers. As a reminder, the items we discuss today are provided for informational purposes only and do not constitute medical or legal advice. As always, you should consult with your own medical and legal counsel. Our agenda and learning objectives for tonight are focused on the issues that you have already or will encounter in the next few days and weeks ahead. At the end of this town hall, you will be able to explain how colleagues in COVID-19 hotspots are combating the virus and list the strategies for billing options and resources available through the SBA and the CARES Act, as well as strategies that ASA is exploring with Congress to ensure that the specialty's economic health is part of the next funding package. The American Society of Anesthesiologists designates this live activity for a maximum of 1.75 AMA PRA Category 1 CME credit. As a reminder, previous town halls are available online and CME credit can be earned for reviewing those recordings. You can find those recordings and accompanying slides at www.asahq.org/townhalls. To begin tonight's town hall meeting, ASA President Dr. Mary Dale Peterson will make a few opening remarks. Dr. Peterson?
Thank you, Sarah, and good evening, everyone. Tonight, we want to welcome not only our ASA members, but also members of the anesthesia care team, anesthesiologist assistants, nurse anesthetists, anesthesia techs, as well as our administrators and executives. We also welcome and value our relationships with attendees from across a number of specialties and other organizations that have worked collaboratively with us through this pandemic. Before we begin, I want to address what happened on Monday, which was, ironically enough, Doctors' Day. Many of you are wondering why President Trump eliminated all scope of practice rules in hospitals, essentially stating that no doctors are needed. As many of you have told me, there are anesthesiologists who are currently out of work with the cancellation of elective surgeries. So there is not a workforce shortage currently in the anesthesia community. My understanding is that the federal government does not want to impede any flexibility that states may need to handle this crisis. State laws and your hospital bylaws will still prevail and should be used to ensure timely and safe patient care, which will be dependent on your surge and your workforce. We should not be discouraged. This is an unprecedented period of time that we must all work through. The Medicare waiver is temporary. Once the emergency declaration expires, so too does the waiver. I've already conveyed my disappointment and concerns to senior administration officials. I will continue those conversations, and at the right time, ASA as an organization will respond more fully. So please stay tuned. I also want to briefly update you on new statements ASA has posted this week in response to the concerns that you have shared with me. I charged Dr. Beverly Phillip with updating our statements and want to thank her and all the volunteers for their expeditious work. First, we have a statement that supports anesthesia professionals having appropriate PPE. And if the hospital can't provide it, allowing us to bring our own commercial grade PPE to wear. Second, I heard from many of you that some hospitals and other professionals were interpreting or misinterpreting our statement on who should intubate COVID patients. Please see our updated guidance. Anesthesiologists are not required to intubate all COVID patients. Experienced ER and ICU physicians are capable of doing this, just like they have been doing in the past. Some hospitals and anesthesia groups may choose to provide this service, but it is a local decision. The intent of the original statement was to discourage these procedures as training opportunities because of the complexity of more people having to wear PPE and the potentially unstable nature of these patients in respiratory failure. I also want to alert you to new guidance as of April the 1st related to converting anesthesia gas machines and fresh gas flows, as well as the resources you need to take care of COVID patients in the ICU. These resources are on both the ASA and APSF websites. Those critical care resources are under the acronym CSER. Finally, we know that this crisis has limited the time available for clinical instruction of residents. ASA is helping to bridge this potential gap by creating a catalog of free education for resident members that is available during this pandemic. Resident members can find these resources at asahq.org/resident-courses or by visiting the ASA Education Center on the ASA website. Now, I would like to bring in our wonderful speakers for our first panel, who will give their firsthand viewpoints from the front lines of New York City, where we've seen 40% of the total cases in the U.S., with more than 85,000 confirmed cases of COVID-19. I'm so grateful that they have taken the time to share the lessons they have learned with us. This first part will be about 45 minutes, including questions and answers, and then we'll go right into our second part, dealing with practice viability and the economic relief package. Our speakers from New York tonight are Dr. Andy Rosenberg, our ASA Vice President of Scientific Affairs and Chair of the Department of Anesthesiology, Perioperative Care, and Pain Medicine at NYU's Langone Medical Center. And we also have Dr. Stephen Schulman, Associate Medical Director and Anesthesiologist at St. Francis Hospital in Roslyn, New York. Andy?
Thank you very much, Mary Dale. Tonight I'm going to be speaking about organizing an academic anesthesia department to respond to the COVID pandemic. And I really don't have anything to disclose. So I want to outline the organizational issues that need to be addressed when planning to respond to the COVID pandemic. I also want to have you understand the vital value that our skill set provides as members of the anesthesia care team in helping to fight this pandemic, and discuss the care teams, equipment, and supplies needed to help the institutional response to the COVID pandemic. So we're in the midst of a devastating pandemic, or actually, if you look at this graph, which was prepared by the Institute for Health Metrics and Evaluations, we're really at the beginning of this. On this graph, you can see April 1st or April 2nd, and actually the one that I had prepared yesterday had to be redone because of the increased projections. But you can see that we're really not peaking until about April 14th. And originally, the suggestion was that we'd have to have about 18,000 ventilators available for today. That was changed yesterday to 21,000 on April 2nd. And we're going to be peaking at about 32,000 ventilators about April 14th, with 39,000 ICU beds. So this is really a pandemic that's coming, and it's going to hit us harder as it comes along, and we're going to really be stressed. A lot of institutions are already having problems getting enough ventilators, and that's just going to be compounded as the situation moves along. But I think that, and can I have the next slide, please? I think that if you're approaching this, you really have to approach it from an organized fashion. And that's going to really help you as an institution, especially academic medical centers and private groups as well, smaller hospitals. You have to really be organized. We've had some experience in New York City. We experienced both 9/11 and Superstorm Sandy. So we had a couple of times where our institutions were shut down and we had to deal with it. And while those were unprecedented situations, we really went to a recovery phase and get ourselves back into gear. When it was the Twin Towers came down on 9/11, we were down for a few days when we had to reorganize and figure out what was happening in the country. And on the bottom picture, you could see what looks like the Chicago River, but it's actually the entrance to the Brooklyn Battery Tunnel, which was completely filled with water. And now our hospitals were down for a few months. So we had these episodes, but we really went into a recovery phase. COVID is different. It's a pandemic with many different issues, and it's just presenting and it's going to be here for a while. So we really need to get our skill set together. As a department, we really were well organized, and we learned a lot from our experiences during the 9/11 and Superstorm Sandy time period. We realized that we had to be organized and we had to be nimble and keep changing and addressing challenges as they occurred. And I was lucky in my department to have so many skilled people who can actually help me from the organizational level. Next slide, please. So what's our role in the academic medical center? Listen, as anesthesiologists, we're really on the front lines, and that's what we're good at. We care for sick patients, we do intubations, we do ventilator management, ICU care, we put in lines, and we prone position patients. All of these are really crucial during this COVID pandemic. So it makes sense that for us as a department to define our role, because we know what we're best at, instead of letting the institution tell us what we should be doing. So really, you want to define your role and show exactly what you could do to help the institution. And I'm very humbled at the conviction, determination, and dedication of our physician anesthesiologists, our nurse anesthetists, our residents, and our anesthesia tech staff. Everybody's been pitching in and working really hard, and it's a real big, good team effort. And it's really been organized well. We're collaborating with others in our institution as well as we do this. Next slide, please. So what are the organizational issues that we're faced? First, at the leadership level, we have to make sure that the department is working well. It's important to disseminate information to the entire department. There are workforce issues that have to be addressed. How do we schedule people? Where should they be? What teams should we be using? What's our approach to the teams? And equipment and supplies. Everybody's talking about PPE, using anesthesia machines. What happens in the operating rooms? These are all things that need to be considered and thought about ahead of time, so you're really not making decisions at the last minute. Next slide, please. So the way I'm looking at this COVID pandemic right now, and we all say it's a marathon because we look how long this is going to be lasting. It's a marathon, not a sprint. But at the beginning, this really seems like it's a marathon that's being run at a sprint pace. So we have to sort of pace ourselves and keep moving and figure out what's going on. I have daily leadership conversations over video conferencing with the leaders at the 4 different hospitals that we have in our system, as well as other key leaders in my department that I need to get input from. And I do get input from these multiple locations. People are providing information about the COVID care that they're giving, and that helps the rest of us determine the needs, share our experience, and determine the next steps that we're going to be taking in care of our patients. This meeting is the video conferencing takes about a half an hour to an hour, and I get everybody to weigh in. And we've really learned a lot from each other. We have a tertiary care hospital, we have a city hospital, we have a freestanding orthopedic hospital, and then we have another tertiary care private hospital. So that's out in the suburbs. And everybody's having different experiences, but we're all learning together. And I think organizationally, that's very important. Then I put together a daily update that I disseminate to the department members so everybody can keep knowledgeable and engaged as far as what's going on, because people are in your department, you'll see there's a lot of variability, but a lot of people are scared. They don't know what's going on, and it's important for them to get information because they feel connected. And the feedback on that has been very positive. I try and address each of the individual locations and what's going on in those locations, and make suggestions to the rest of the people about what's going on at specific locations. And I also think it's an important opportunity to express gratitude to the members of the department for working so hard. It's also important to consider the emotional state of our personnel. Some of the people are fragile, they need support, and other people as well like to hear that about the great job they're doing. So we give references for people where they can check in for support and other wellness opportunities. Next slide, please. So the first thing that's important is that you have to account for all your staff. And as you're organizing your staff, include downtime early on because you're really going to need everybody working together later as this really hits. And we've been trying to do that even in New York when we've been getting hammered right away. We've discussed issues such as scheduling, vacation, the call schedules, how to handle that, overtime. And basically, we came to the decision as an organization to move into shifts. We no longer have weekends or weekdays. There's no call, and we just do shifts, and that's organized that way. We collaborate with all the locations to determine who's assigned to each of the locations as we're doing our scheduling. Next slide, please. Uh, and we've centralized our overall schedule so that one person is actually the lead scheduler for all the anesthesiologists, nurse anesthetists, and residents in our organization. So we're organizing hundreds of people. That person's a very, very critical resource, but we do have redundancy because one of the things you're going to find out is all of a sudden somebody gets sick and they're out for a week at least, and they have to be out after that for 72 hours having no fever. If those overlap, that's fine, but you're going to be losing people for a while. So it's very important to get redundancy. So you want to define your teams and your team leaders and let the team leaders help make their schedule. As I said, you want to take into consideration that you're going to be losing staff for varying amounts of time. We have a resident COVID tracker. We follow our attendings. And then before anybody comes back, we wanted to meet with have a conversation with one of our leaders to actually understand, are they ready to come back or not? And you have to be flexible in your staffing needs as different staff needs increase in different teams. For example, the intubating teams need more people. Next slide, please. So what staff are we dealing with in an academic medical center? We have a physician anesthesiologist. Those are anesthesiologists who work in the operating room, as well as our intensivists. We have nurse anesthetists who are a critical part of the team, the residents who are a critical part of our team. They all play an important role, so we want to make sure that they are not deployed elsewhere in the institution. One of the things that we heard right away is that they want to be pulling the nurse anesthetists away to another area. I think it's important to keep them on the team because everybody's valuable to you. Schedules should be organized on a level and fed into the team schedules. And you also want to make sure that if you're deploying your anesthesia machines to different areas, that you have anesthesia techs there as well to help keep up with the supplies and equipment. Next slide, please. So the first thing is what happens to your OR teams. And I think Mary Dale mentioned before that there are a lot of anesthesiologists who aren't working. And we certainly are doing less cases and we're doing only emergencies. But I would maintain some of these call teams or these OR teams in the shifts because they're really good for on-site backup. We've had a few nights already where we've had some surges and we've needed some extra people, bringing some machines around, helping us do the intubations. So it's good to have that on-site backup. The ICU attendings, early on, it was probably 3 weeks ago, I took all the anesthesia intensivists off of the OR call schedule and freed them up to be 100% intensive care physicians. And they're being used because every day we're opening new COVID ICU floors and they're really helping out a lot. We have a second pool of anesthesiologists. So you should think of your organization, who is doing the really difficult, complicated cases, like your transplant anesthesiologists, who may be able to serve as ICU physicians as well, even though they're not certified, because it's all hands on deck. And the anesthesia care team in general is really helping out with vent management and other issues. We've had excellent collaboration among our attendings, our nurse anesthetists, our residents, and our anesthesia techs, because we have to educate the floor nurses about some of the important things because we're bringing up anesthesia machines and they've never seen them before. There's a big learning curve to this, so it's worth spending the time. So we developed some teams called the AVPP team. Next slide, please. So the AVPP team, AVPP stands for Airways, Ventilation, Procedures, and Prone Positioning. And these are really the important areas that we're involved with. Obviously, airways, we're doing the intubations, ventilation management, we're managing the ventilator settings and making sure we have enough supplies and equipment necessary. We're doing procedures, we're placing a lot of lines. On the intensivists and all the floor people are really, really appreciative of the A lines and central lines we put in. And one of our locations, we're even offering to put in regular IVs because there's not enough staff to help do all this work. Prone positioning. So I hope everyone saw the excellent talk that Dr. George Williams gave at the last webinar, where he was describing the benefits of prone positioning. We're excellent at prone positioning. We've done it for years, and we really know how to do that. We have both our attendings and residents a part of these teams, and that's one of the things that we can get an advantage of in an academic medical center. And these teams are really appreciated by the clinicians and the hospital leadership. As you develop your prone positioning teams, though, I would suggest that you just don't have it be the anesthesiologist. There are a lot of people around the hospital. You have the scrub techs who have been helpful in positioning patients. You have some of the surgeons who are helpful. So get them, get the nursing staff to help move the patient into the prone position. Next slide, please. I think one of the key things that we could do as anesthesiologists is collaborate with others. We personally work in a very large organization, so it's important to let people know what's going on and what your department is doing. I'm lucky at NYU, we have phenomenal leadership at the administrative level, from the dean's office down. They're very interested in patient care. They're very interested in the employees and the physicians, the nurses, and all the staff who work in the hospital. So it's important to have them understand what's going on from your department, what you're doing and your roles are. And that way you're having a conversation and they can ask, what can I do to help you get done what you need to get done? We also, a couple of leaders in our department, participate in daily briefings, so we understand what new floors are opening, what units are opening, what the staffing models are for those units, and whose ventilators they'll be using. I've been working with ID a lot. The infectious disease people are really good. We have frequent conversations. I actually had a webinar with one of our ID physicians to the department, and that enabled our department people to ask a lot of questions about managing patients who are COVID positive, PPE, and gave them a little bit more reassurance and understanding that people are there to back them up. Because this is a constantly changing landscape for the definition of who should be wearing PPE, who should be wearing masks, what should be happening in the perioperative area. And I think it's really important to have that good collaboration with the infectious disease specialist. Next slide, please. The ICU personnel are really important to talk to as well. You want to really define where to best deploy your people. The emergency management key, I have a really good relationship with the emergency management people, which is important. Those are the ones who make sure you get your needed PPE and the other supplies and equipment you need. And I think that that's really, really helpful in a large organization. Respiratory therapy, how many vents are there? Where are they going? Which machines are being used on which floor? Are the servos better than the LTVs? And whether the anesthesia machines fit within this whole scheme of caring for patients. So you can know where your anesthesia machines are, you know where you're going to be deploying them, and you have an organized approach to managing and maintaining them as well. Next slide, please. As far as your equipment is concerned, you should account for all your supplies and equipment, have somebody in charge of that, centralize your anesthesia machines from all your ambulatory and off-site locations, get those trucks out there and bring them in. There are a lot of anesthesia machines out there that we don't know when the surge comes, we may be using all of them. Keep a daily tally of the anesthesia machines and their locations, both those in use and your spares. And I think it's important to let the people who are working overnight know those numbers, know where the machines are, so in case there's a surge, they can run and get the machines. And if you think you're gonna need something down the line, get it now or plan how you'll get it and procure it later on, because they're gonna be running into a lot of shortages. So, and also know where your supplies and equipment are stored. I think it's important to talk to your operating room personnel and the people who run the environmental areas and understand which of your operating rooms can be negative pressure. We have a new pavilion, so basically every operating room could be negative pressure. We've already established which operating rooms are going to be kept at negative pressure, so we don't have to ask that to be changed from different times. So we have 2 operating rooms on each of our 3 floors in our new building that are negative pressure rooms, and I think that's really important to do. Next slide, please. If you're going to use your anesthesia machines, there's a lot written about that on the web, so take a look at that. Gain experience. Try and cohort your anesthesia machines I think we've done that nicely. We're using them on one floor so that we can have our anesthesiologists, our nurse anesthetists, our residents, everybody who's helping out with the management be there and understand it. I think that it's also very important, if you do have anesthesia intensivists, try to have them work on the same floor as where your anesthesia machines are. It's really, really valuable. We've got our institution to buy into that because you can have good discussions about what's going on and how much PPE you're putting on the patient, what the flow is, thinking about your CO2 absorbers, the water traps, the filters. They're speaking the same language as you are, and it's very, very different from having a medical intensivist discussing your anesthesia machines with you. The other thing to think about with your anesthesia machines is that how many machines can you put in an operating room? Because they're talking about, we've heard the discussion about two people being placed on one ventilator. I think if you can get enough anesthesia machines and bring people into these negative pressure operating rooms, you can think about all your different oxygen sources in your operating room. In some of the new operating rooms, we have double sources for oxygen, and actually on the surgeon stands area, there's also a third source. So we can run at least 2 ventilators in those rooms and sometimes 3. So just take some time to think about that and get your anesthesia machines if you need them. Next slide, please. So I think I just wanted to summarize by saying I hope I gave you some ideas about developing an organized approach to this crisis. I think each crisis is different, but as anesthesiologists, we're used to being flexible, and we need to use that ability to help our institutions and the country fight this issue. As anesthesiologists, we certainly have the skill set to play an important role in this disease process. I think good leadership and organization sends a positive message to the institution and to your staff so they know that things are under as much control as possible. So be safe out there, and thank you. And now I'd like to introduce Dr. Steve Schulman, who's going to talk about smaller private practice groups. Steve?
Thank you, Andy. So my name is Stephen Schulman. I'm the Associate Medical Director at St. Francis Hospital in Roslyn, New York, and I'm also the President of New York Cardiovascular Anesthesiologists. Next slide, please. So tonight I'm going to talk to you about my hospital, where we are, what we do, give you a perspective on a suburban community hospital response right next to this pandemic, and also talk particularly about what we're doing as a private practice. Next slide, please. So in Long Island, we have a number of different hospital systems. St. Francis is a part of the Catholic Health System of Long Island. We also have a big presence from Northwell, NYU Winthrop, Mount Sinai, South Nassau, Stony Brook, and Nassau County Medical Center. So we have a mix of private and public hospitals. Next slide, please. St. Francis is located in northwestern Long Island. And as you can see, we're really right adjacent to Queens and the Bronx, which is really some of the biggest hotspots in the country are right now. Next slide, please. So we had 224 med-surg beds, 60 ICU beds, 20 operating rooms. And of these 20 operating rooms, 6 were cardiac, 14 general, and we had 60 ventilators available. And we also have an association with an ASC that has 5 rooms. Next slide, please. I'm going to talk about what we did as a community hospital next, starting with the timeline. Next slide, please. So on March 1st, that was only a month ago, but seems like a really long time ago, the first coronavirus patient was identified in New York. By March 6th, the first patient was identified on Long Island. On March 7th, the governor declared a state of emergency. And on March 22nd, the governor mandated cancellation of all elective surgery, which is to go into effect March 25th. On March 23rd, my hospital canceled all elective procedures. And that same day, Governor Cuomo mandated every New York hospital increase our capacity of beds by 50%. On March 30th, we closed all of our general ORs, 14 ORs, such that all emergency surgeries were relocated to the Heart Center OR. So all of our cases were going to only 6 ORs and are still. Next slide, please. So as a result of the governor's mandate, we have increased our med-surg beds to 336. We've increased our ICU beds to 94. We only have 6 operating rooms now, as mentioned. Next slide, please. And this slide has been updated every day. This just gives you an idea of how many patients are positive every day. And even as of tonight, these numbers are significantly higher in that we had, just yesterday, we had 147 COVID positive patients, 66 PUI. Our ventilators available, again, we started with 60, and then we were down to 14, then 8, 6 as of this morning. But we've just been told we're getting 15 ventilators coming from New York State. So as of yet, we don't have to use anesthesia machines, but we are prepared to do that. In addition, because of the cancellation of all elective surgery, we took our ASC down to 2 rooms, which are only for emergent cases, but we'll talk more about that later. Next slide, please. So communication with regional anesthesia leadership. When I looked back at this slide earlier today, I saw how it could be misinterpreted. This doesn't mean in time of crisis that everyone should be calling ASRA and asking them for advice. What we're talking about is talking to other private practices in the area. Our group's private practices traditionally exist in silos, but it's so important to communicate with the other anesthesiologists and other hospitals to really find out what's going on there and to compare notes. And we've done this through a number of hospitals in Long Island by group texts, conference calls, video conference. And some of the information that we share regularly are our clinical experiences, what we're seeing and how we're doing it, what kind of PPE is available at each hospital, what we're doing with our workforce. Our workforce has totally changed now with the cancellation of all surgeries. So what are we doing with our manpower? And also reimbursement strategies is really important in a private practice. Next slide, please. So we also have to have internal communication as well as external communication. Very early on, we spoke to the chairman of the emergency room, director of critical care, and also respiratory therapy. We talked to the group numerous times, the shareholders, CRNAs, employed physicians, everybody, just to talk about what was coming. The plan for intubations is different in a small community hospital as it is in a major academic medical center like Andy's. In our hospital, we don't traditionally do the intubations on the floor. They've always been done by respiratory therapy, and we get involved perhaps for a very difficult intubation. So with the recommendations from some societies and maybe some misinterpretations, we had early conversations, and we had to talk about who would be doing these intubations, and if we were going to be involved, would we be involved 24 hours? And I'd really say that we had very successful talks. We have a multidisciplinary approach to intubations now, where critical care, ER, respiratory therapy, and anesthesia are all involved, and we all share the burden and share the risk equally. The other issue is critical care coverage. As Andy mentioned, in NYU, there's a number of critical care trained physicians, and we have several. We have 2 in my group who are critical care fellowship trained, and we've worked towards getting them rotated in with the intensivists. Next slide, please. We also established a surgical case review committee. Governor Cuomo mandated us to suspend elective surgery, but elective surgery is frankly in the eye of the beholder. So we put together a team made up of the surgical chiefs, organized by the chief of general surgery, with representatives from anesthesia, nursing, and OR scheduling. And this team meets daily at noon, and they discuss the cases that are booked for the following day. And they triage these cases based on the urgency, whether they are believed to be true emergencies or they could wait potentially 3 months, which is the landmark that we're saying for an emergent case versus a non-emergent case. And then the logistics. How long of a length of stay is this patient going to need if they come in? Do they need critical care? Do they need resources which are in short supply? And then we also look at options. We really never did breast cancer surgery at our ASC before. But now these patients really shouldn't be waiting 3 months. We've explored using our ASC for some of these urgent, but not emergent, but not truly elective cases. And so that's an option, is to look towards your ASCs for some of these cases. Next slide, please. Now let's talk about specific concerns for a private practice. Again, the name of my group is New York Cardiovascular Anesthesiologists, and I'm going to talk about a number of issues that we faced. Next slide, please. So my group has 50 total employees. We're made up of 28 shareholders, 31 call-taking physicians, 4 non-call-taking physicians, and we have 16 CRNAs, 8 of which are full-time, 8 are per diem, and we have an office staff of 7, and we outsource our revenue cycle management. Next slide, please. Very early on, it's so crucial to talk to all of your key external support systems. We very early on, as soon as we realized what was coming, we talked to our lawyer, we talked to our accountant, we talked to our banker, and we talked to our billers. And in many instances, we had them talk to each other because everybody needed to be aligned. I heard a great quote today that what we're facing isn't a game of checkers where you just look one move at a time. It's really a game of chess. And you have to think several moves ahead, and you have to anticipate what's going to be happening, not just next week, but several months from now. Next slide. We had frequent emails within the department, and we really use video conferencing. I frankly had never really used video conferencing at all, and now I find myself on multiple meetings a day. It's a great way for us to communicate with the CRNAs, and it was a great way to have shareholder meetings, and we have weekly shareholder meetings now, and we have a greater attendance than we ever had in a regular face-to-face meetings. Next slide, please. So what are the financial considerations with a private practice group? Well, first thing you have to look at is what are your accounts receivable? What does your cash flow look like over the coming months when we have canceled all elective cases? And when I had this discussion a couple days ago with Dr. Rosenberg, I'll give him credit, and he said, you know, with your revenues, you have to flatten the curve also. You have to do what you can to make your revenues last as long as you possibly can, and that's really what we've done. You have to look at your staff and your per diems. Frankly, our per diem CRNAs were the first to be told that we wouldn't be needing their services anymore. And then you have to look at your full-time employee CRNAs and your full-time physicians. And you have to look at the contracts, and you have to make some decisions about how you will allocate these resources. There's a consideration to use your CRNAs as ICU nurses, and there certainly is a shortage, and there certainly is a need. And that's certainly a direction that we looked at. And frankly, we really thought that we were going to have nurses working as in the ICU. But the truth is that a lot of these nurses are not comfortable with the charting requirements. They're not comfortable with some of the responsibilities that come with an ICU nurse, and excuse me, and not all nurses are going to be willing to embrace this possibility. And transparency is really important with everybody you're dealing with. Next slide, please. So some of your financial options you need to consider. Again, I mentioned critical care coverage, and our hospital and most hospitals in Long Island have been very supportive of having help in the ICU. They've really been very generous, very forthcoming with reimbursement to having our nurses work in the ICU and to compensate us at least at what they're getting paid now, if not full per diem rates. There also are, there's been a lot of communication with the hospitals regarding using anesthesiologists as critical care physicians. And the use of anesthesiologists in critical care, you have to decide whether it's better to do that as a fee-for-service or with direct hospital support. And that's kind of an individual decision, and you have to look at your own payer mix and what the hospital is willing to offer. Many hospitals, including at NYU, have teams that are out there to do intubations, lines coverage, maybe assist the intensivist 24/7. And again, this is hospital by hospital. St. Francis Hospital, literally, we just started this last evening, was the first time that we have anesthesiologists in-house as another set of hands, and we expect this to expand going forward. And again, talk to your hospital leadership proactively before you need this, because the hospitals have been very, very supportive of this. The other thing to consider are the SBA loans, Medicare advances, and potential line of credits with your bank, and this will be talked about in the later presentations. Next slide, please. So what are some of the key lessons that we've learned through this process? Remember, when you talk to your lawyers, you're getting legal advice. And the lawyers will often push you in a direction saying, well, this is what the contract says, and this is really what you need to do. They're working for you. Remember that the lawyers are giving you advice, and as shareholders, as owners of your corporation, you really need to evaluate that advice and see, is that the best path for you to take? Because it might not be. And you have to understand your risks if you don't take their advice, but oftentimes there's a better direction for the corporation to go. You have to remember your responsibility as business owners. when talking to your employees, you have to share the pain. You have to make sure that everybody knows that we're in this together and we're taking a financial hit. And if you're going to be taking a financial hit, we're really all doing this together. I think it's great to crowdsource ideas when you talk to your employee physicians, your CRNAs, even your shareholders. Everybody knows what's happening with volume and the decreased revenue with decrease in elective surgeries. So talk to everybody, see if there are some interesting ideas, if people are willing to take unpaid leave for a period of time. Explore all options that don't lead you down towards termination or just making a relationship something that you're not going to recover from long term. And most importantly, empathy. None of us have ever been in this situation before. The nurse anesthetists have never been in this situation before. Your employee physicians, your shareholders, really lead with compassion. Start the conversations off with compassion. We're all in this together, and I think that will lead to the best outcomes. In conclusion, I just really want to thank all the physicians at St. Francis Hospital, and especially all of the physicians and nurses in my Department of Anesthesiology, with a special shout out to Robert Cates, my clinical chairman. Thank you.
Thank you, Steve, and thank you, Andy. I really appreciate all the hard work that you've done. We've got a few minutes for Q&A, and I just want to let everybody know that is either asked a question in the chat box or put it in the Q&A, that we are taking all those questions and we're putting them into our FAQs. I know we've had a number of questions tonight on the use of N95s, and we provided updated guidance a couple of weeks ago that ASA, along with AANA, really believe that N95s should be used by our providers in all aerosolized generating procedures. So what is that? That would be at intubation and at extubation. And that's regardless of whether you know the patient has a COVID positive status or not, because really it is in most of our communities now. And we do know there's about a 6 to 13% either pre-symptomatic or asymptomatic patient that you just don't know based on symptoms. Now, to our panelists, I think that the question I have from Jim Kelly is, we have some physicians in the Midwest who do not believe this pandemic will impact us. Can you please describe the New York experience to help us explain to our non-believers how serious this is? So maybe, Andy, if you would start with that, and then Steve, you can chime in as well.
Okay, so I think that we have to consider that every single patient that we're taking care of is COVID positive. I think that all our anesthesiologists and nurse anesthetists, anesthesiologists should be wearing PPE and N95s when they're taking care of patients in the operating room. I think that the way to explain that to anybody who says you shouldn't be getting this is just look at the progression that we've been doing in a lot of hospitals in New York. At the beginning, nobody was really wearing any N95s. People were walking around the hospital. Now, everybody's in the hospital wearing masks. Most of the people, there were some people walking around wearing N95s all day long, and that's really where we're going. So if they want to protect themselves, if they want to protect the hospital staff, if they want to protect the patients, and then people at home, start being smart about this.
And I'll address the second part about physicians in the Midwest potentially not thinking that this is real or going to become a true pandemic. So I was off for a couple of days. Again, elective surgery was canceled. There was no clinical need for me. And I worked last evening. And when I left the operating room to just walk through the PACU to go to the floor, I was very unsettled because it's my PACU. That's where I bring out my patients, my total hip replacements, my thoracotomies. And walking through and seeing a complete COVID ward, that every patient there was on a non-rebreather or on a CPAP machine. Every patient was very ill. All the nurses were in their full PPE gear. This is my home. This is where I've worked for all these years. And it's changed that dramatically in 2 days. You go up to the floors, every door is closed. All the nurses have a high level of anxiety. This is real. And day to day, it changes so quickly, I can't begin to tell you.
Thank you both. So another question that's come up, and this has probably been a subject of the most media requests I have gotten, and that has to do with splitting ventilators. And I know ASA and 5 other organizations really believe that this should be the very, very, very last choice because of not the technical issues of putting a Y or a T connector and putting it to 2 different patients, but the fact that the patients need to be around the same size and at the same stage of disease or have the same area type of lung compliance. So I want to ask Andy first, are you splitting ventilators, and do you know if anybody's doing this, and how are you managing your ventilator supply? And then I'll go to Steve.
Okay, so we're not splitting ventilators. I know there's a lot of people say you shouldn't. I don't really know what's going to happen down at the end of the line, so I can't say that we shouldn't do that. I don't think we want to let patients die rather than split ventilators. So I'll leave that as an open question. We've had our respiratory therapists do modeling to get an idea of how they're going to be using the ventilators and which ventilators to use to do that. So I think it's an open question. I think there's a lot of discussion. I think it's like the PPE question. Once you understand that you have to wear that, you do that and you move on. And that may be the same situation with splitting ventilators. We're not doing it now. We could spend a lot of time discussing it, and then you can go in the rooms and do what you have to do.
Right, and we still have a number of extra ventilators. We have all of our anesthesia machines. We've heard anecdotal reports around New York City about people doing it, but I haven't heard any direct confirmations or had any conversations.
All right, well, thank you very much. I've got a question here about medical licensure, and what if doctors want to go and help out our colleagues in New York? Will the governor or the hospital allow them to come and practice there? Andy?
So they keep asking for physicians to come. We've had some people who have actually asked us if they can come, so we've started working on some credentialing. I do believe they're going to make it fairly easy for people to get credentialed. I'm not very versed in the details of that, though.
All right. And what do you do when you're intubating patients in the operating room? Do you have other staff leave the room or stand 3 to 6 feet away, or what do you do with that, Steve?
Staff is typically, it's pretty much a typical as it was before. I'll have somebody at the airway, one person at the airway helping me. But what we'll do is on all cases, we'll wear an N95. And again, just to conserve resources, is we'll put a disposable surgical mask over on top of the N95 for all of our airway procedures.
So, but it's just the people participating in those airway procedures that are wearing the N95s, not every single person in the operating room. Is that correct?
That's generally correct, yes.
Okay, great. And then I know we've had some questions.
They're
Go
moving
ahead, Eddie.
Yeah, they're moving on to having more people wear them. So I think everything changes day to day.
Got it. Of course, we're dealing with, right, a critical supply issue. And so are you all reusing your N95s or using them for extended use or using some of the sterilization processes that have come online recently? Andy?
All the above.
Okay, can you talk a little bit more about that? So do you like issue one a day or what?
Right. So, you know, early on, we were able to get PPEs, and you just had to be, take good care of them, you know, and the whole thing has progressed over time to having them last for a while and reusing them. And now we're instituting a reprocessing program. So hopefully that'll be really good in getting more fresh PPEs as we need them. But clearly, if you're taking care of somebody and it's an aerosolizing event, you have to really consider, should you be using that or get rid of it? And if it's obviously contaminated, you're not going to keep it again. So. Okay.
Right, and I know recently, and this should be in our FAQs on our website, but Steris, which is a lot of the way you sterilize a lot of your instruments in your OR, came out with guidance on how to reprocess N95 masks and sterilizers really that you already have. So that might be a choice for some institutions to be able to re-sterilize their N95s if they're short of it.
Right, but that's where I come to the point where I was talking about working with your emergency management people, because we've been really lucky in getting the supplies and the PPE equipment we need. So connect with them early on and have a good relationship. You get what you want. And that's what I was saying. Our leadership is very good on helping us with that.
Well, thank you so much. We're a little bit over time on our Q&A, but I think our Panelists have done a fabulous job. And for the second part of this town hall, which will last about an hour, we have Stephen Gomez and Ginny Blow, leaders within the ASA, anesthesia administrators and executives membership category. And they're going to facilitate a discussion on how COVID-19 has affected practice administration and finances. That discussion will also include Sharon Merrick, Nora Matus, James Kim, and Manny Bonilla, our ASA Chief Advocacy and Privacy Officer. So we will set aside a few minutes for questions after that session as well. Steve, can you lead us off?
Thanks so much, Dr. Peterson, and good evening, everyone. I would like to say it's a pleasure being with you, but unfortunately, under the circumstances, I think everyone is being tested. We're all working in uncharted territory, and the community of ASA is rising to the challenge. It's there for all of us as we navigate them. And if ever there was a time for your manager, your administrator, your executive to be a member of the anesthesia administrators and executives section of ASA, it is now. Our partnership is bringing together clinical and administrative resources, which together are critical. All hands are on deck in meeting the needs of this crisis. As you can see in this slide, everyone is feeling the squeeze in healthcare. And that squeeze is not just in your chest, it's in your pocketbook. And we're going to be talking tonight about some of the resources available to you and some of the practice plans that you might want to engage in to deal with this. First, it's important to establish, as I think you've heard from our New York colleagues, that conditions and resources are all local. And so your plans need to reflect this. Every state has not been impacted equally, and so the timeline for your strategies will change from locale to locale. If you're not hit hard at this time, it's an excellent opportunity to plan. If you have been hit hard, then you're constantly adapting your plans to meet those current needs. This is a hard time for everyone, but we can and will get through this. Step one. It's important for you and your practice leadership to establish priorities. First and foremost, the safety of your anesthesia personnel, the services to your patients, and identifying those resources that are available to assure the ongoing operations, not only during this event, but what is going to be needed to assure a viable organization or anesthesia department after this event. And this event will be over. And then, based on these priorities, establishing an action plan. None of us have a crystal ball. We don't know when our communities will begin to flatten that curve and be out of it. But based on what we do know today, it's important to establish a plan of action, one that probably looks at a 4 to 6 month horizon. Resource assessments during that time, the personnel needs that you have for full and part-time. As mentioned before, understanding your cash flow, your accounts receivable, what are the sources of your stipends, and what's the likelihood of them to be ongoing? What are your collections? It's also important for you to take stock of your current expenses. What's variable, what's fixed, and what can be modified. One area for exploration is your malpractice expense. You can look at negotiating with your carrier if your caseload has been reduced and your staff time demands have been accordingly reduced. You may be able to reduce their coverage to part-time and save your practice significant dollars. But in looking at your plan, you also need to figure out, as has been discussed before, how you can fairly and sustainably implement this plan. What will be the impact on shareholders and partners who will be expected to shoulder the lion's share of the burden? What about non-MDs and CRNAs? What will be their impacts as a result of this plan? Benefits impact. You need to assess essential versus non-essential. Health insurance versus CME, PTO, and the like. Conveying that as operations return to normal, all staff will share in the benefits. if ever you want people to have confidence in the transparency and the quality of your organization's caring, it is helping them to understand that as you return to recovery and good health, everyone will benefit from that. Next slide, please. Some of the practice issues that you will face. You want to create expectations of modifications as demands change. This is a very fluid situation, both locally for your practice and nationally. We're constantly having to adapt and adjust to the current information that we have available to us in our practice. Your relationship with your facilities will be tested. If you had a great relationship going into this, that is going to get cashed at this time. You're also going to be able to utilize the quality of those relationships with your facilities, not only in terms of stipend support, but personnel transfer, but also perhaps as equipment is needed. As ASCs and ambulatory facilities are being shut down or reduced, they may be available sources of supplies, personnel, and anesthesia equipment. It's important to work with all of your professionals to explore what federal, state, and local resources for support are available. Prepare and submit those applications and supporting documentation as soon as possible. Jump on it. But again, we'll be hearing from Nora and Sharon later on this evening about those resources, and the policies around them and the regulations are being updated daily, if not hourly. So you want to stay tuned to that, and you want to act on them as quickly as those resources are available to you. Explore and pursue the support of staff safety equipment, PPE supplies, aerosol boxes, anything that might factually help support your staff. You have a role in acquiring. It's not just hospitals, it's not just surgeries, but you as practice administrators can also access supplies and equipment to assist your staff. Another key point that is important to remember, and it's been brought up before, is communicate, communicate, communicate. Everyone is looking forward to the clinical administrative leadership to help guide this process as we both go into this event, through it, and exit from it. You cannot over-communicate with your staff about clinical and safety policies, about staffing, about variations in caseload, impacts on compensation, PTO, benefits. It's important to hold, as has been discussed before, regular conference calls, using go-to-meeting resources, Zoom sessions, being as transparent and informative as possible. Because in the absence of this kind of regular communication, your staff will fill in the gaps, and those will be fueled by their anxieties and pressures and stressors that they're experiencing, both professionally and personally. So anything you can do to convey the care that leadership is providing is critically important. Finally, we're all in this together, and it's important to remember that your staff knows that leadership cares, that we're planning and executing strategies to support them, and that we remain open to change as new issues and opportunities arise. We can overcome this. Now it's my pleasure to introduce Jeannie Blau, who's going to help facilitate the following discussion. Jeannie?
Thank you, Steve. Like many of you, I'm very concerned about our anesthesia groups and practices that were already operating on thin margins, pressed by surprise medical bills and production pressures. And as Dr. Peterson mentioned, I would suspect that most anesthesiologists share that concern and want to know what's on the horizon for their groups. What can they do? How can they take advantage of the federal resources available? And when you think about it, with nearly 50% of the anesthesiologists working in small to medium groups of 50 or less, the strain on resources, both financial and human, are amplified. The COVID battle will stress these practices to unimaginable limits, and we're already hearing of proactive planning from the ranks. As all practices are working to provide services, the human toll of stress and burnout should be recognized and addressed. Be aware of your partners, your staff, your colleagues, and pay close attention to any changes in communication and behavior. It's going to take a cohesive team of anesthesiologists, CRNAs, AAs, schedulers, accountants, administrators, and more to guide your practice through this crisis. But as you said, Steve, we are all in this together. So our first speaker from the Washington, D.C. ASA office is Sharon Merrick. Sharon, as many of you know, is the Director of Payment and Practice Management. She will be discussing billing for critical care, telehealth regulations, and accelerated payments. Sharon?
Thank you so much, Jeannie. And if we could just move to the next slide, please. So right now, your practices are facing truly steep economic challenges while you guys are on the front lines of the COVID battle. So in my short time with you this evening, I just want to take it to make you aware of some options you have right now for some immediate cash flow into your practices. I realize that the amounts of some of this cash might seem small in scale and scope compared to the catastrophes that we're facing. But at this point, you just want to keep, you stop the bleeding and you keep cash moving just as much as you can. So in these next few slides, we're going to talk a little bit about critical care, telehealth is an option, and Medicare's accelerated advanced payment program. Next slide, please. So critical care, this slide gives you the two codes, the CPT codes that describe critical care for adult. And notice that one is an add-on code, always reported in conjunction with the first one. 99292 gets reported with 99211. The criteria, these codes, to report them, the patient and the care have to meet certain criteria. The patient has to have a critical illness or injury so that there's high probability of imminent or life-threatening deterioration in his or her condition, which would certainly be the case with a COVID patient that requires critical care. And the treatment has to involve medical decision-making that is so complex because you're assessing, manipulating, and supporting all those vital life functions. It doesn't mean that the patient needs to be in an ICU. The patient could be anywhere, but as long as the patient meets the criteria and the care meets the criteria, you can report critical care services. These are time-based codes, and just like anesthesia, there's rules about what's included in your time and what's not included in your time. The timely topic and the more information link on this slide gives you more information about that. Anesthesiologists may not be providing critical care per se, but you may be providing ventilation management. If you are providing vent management and not critical care, report that vent management code. If you are reporting critical care, the vent management would not be separately reported, it's bundled in there. The final point on this slide is the amounts on the slide. The payment amount is what Medicare allows per the fee schedule right now. And as you know, ASA has been promoting and advocating for enhanced payment for services such as critical care that anesthesiologists are providing right now to COVID patients in this environment. So hopefully we'll be able to report some success for that. Next slide, please. Telehealth. In this challenging environment where so many of us are under stay-at-home orders and where hopefully all of us are practicing social distancing, telehealth could be a real option for some practices, and also think about it for pain practices where you can continue to provide the care your patients need while mitigating the risks of exposure to them and to yourselves. In this past week or so, there have been changes announced about telehealth at a rate and a frequency that I don't believe I've ever seen before in all my years of doing this. Some of the more notable ones are on the slide here for you. The patient does not need to be, the patient can be anywhere in the country, anywhere, any patient, anywhere is now eligible for telehealth services. The originating site, which is where the patient is, can be at the patient's home. They don't have to go to a special designated site. And the distant site can actually be the provider's home as well. The list of services that CMS allows to be performed via telehealth has been expanded. 80 more services, I believe, have been added to this. You may even want to consider for a pain practice continuing to do telehealth after the crisis is over as another way to sort of be able to enhance revenue, enhance patient care, and get yourselves back on your feet a little bit after this crisis is over. But do remember, many of the loosened restrictions may tighten up again after the public health emergency does end. So you want to make sure that you stay aware of that. Information is in the link here on your slide as well. Anesthesiologists may even want to consider telehealth if you're working as an intensivist, because of those 80 codes that have been added to the list, critical care, the two codes 99291 and 99292, are now on the list of services that can be performed via telehealth. And if we could just move then please to the very last slide, where I want to talk about CMS's Accelerated and Advanced Payment Program. This program has been in existence for many, many years. Typically, it's used like for hurricanes, floods, things like that. Anytime that there is a disruption into the claims submission and the claims processing systems. It has been expanded a little bit for the duration of the PHE to include more providers are now eligible to make the request. The amount of the money that you can request has been increased. Right now, you can request up to 100% of your Medicare payments for a 3-month period. And what they're using for that 3-month period is the fourth quarter of 2019. And also the recoupment has been changed a little bit as well. Starts at 120 days. You will make the request through your MAC, your Medicare Administrative Contractor. The fact sheet that is linked to this slide includes step-by-step instructions that you can follow to make that request. This could be a way to get cash in your door quickly because the MACs are committed to reviewing and approving those requests within 7 days of the receipt. However, do remember that this is not a grant. You do have to pay it back. And the way it works is 120 days after you've received the money, CMS will then start when they receive your claims, rather than issuing you payment for those claims, just withhold that money, and they will continue to do that until the amount that you have been advanced is repaid. And if it is not repaid within 210 days from date of issue, then they will ask you to write them a check. And if you are unable to do that, interest may accrue at the rate of, I believe, of 10.25%. Again, lots of information on that fact sheet as well. And with that, I'm going to turn this over to Jeannie and look forward to your questions at the end of the panel.
Thank you, Sharon. That's some very valuable information. Next, I'd like to introduce Nora Mattis, ASA's Director of Congressional and Political Affairs. And Nora's going to discuss features of the recent CARES Act as it relates to anesthesiologists and their practices. Nora?
Thank you, Jeannie, and good evening, everyone. I hope this finds everyone well. Next slide, please. In recent weeks, Congress has passed and President Trump has signed into law 3 large bills to address the COVID-19 pandemic. The first bill allocated $8.3 billion in emergency funding for COVID-19 prevention, preparation, and response efforts. Phase 2 expanded COVID-19 testing and provided paid sick leave and unemployment benefits for workers and their families. Tonight, we're going to be focusing on the economic relief provisions of Phase 3, the Coronavirus Aid, Relief, and Economic Security Act, or the CARES Act, which was passed unanimously by Congress and signed into law by President Trump last Friday. The CARES Act will not solve all the problems that you and your practices are facing. It will provide you with some tools to help you maintain your practices through the challenges posed by the pandemic. In sum, the CARES Act provides $2 trillion in overall federal assistance to families and businesses. Following this webinar, you can access links to the agency websites and, where available, directly to loan and grant applications from the ASA website that you see here on the screen. And I'd encourage everyone to check back frequently. As Sharon noted in her presentation, regulations are changing and updating frequently, and we try to keep that site updated for you. Next slide, please. So with funding of $100 billion, the Public Health and Social Services Emergency Fund is probably the most eye-catching provision of the CARES Act. It's designated to provide immediate relief to eligible healthcare providers for healthcare-related expenses or lost revenues attributed to the COVID-19 pandemic. All healthcare entities that provide healthcare, diagnose, or test are eligible for funding. And make no mistake, competition for this funding is going to be fierce. Non-reimbursable expenses attributed to COVID-19 for funding, including, among other things, personal protective equipment and revenue foregone from canceled procedures, all qualify. This fund is designed to be immediately responsive to needs, and the Secretary of Health and Human Services will release the funds to healthcare entities on a rolling basis as qualified applications are received. The Secretary is expected to release guidance on the application process very shortly. Next slide, please. We've heard many concerns from physicians about being able to maintain their practices as a result of the pandemic and cancellation of elective surgeries. The Small Business Administration is offering loan programs, often with loan forgiveness. The SBA Payroll Protection Program provides loans up to $10 million to help retain employees on payroll. Through the Payroll Protection Program, a physician practice can apply for a loan of up to 250% of their average monthly payroll costs to cover payroll, as well as rent, mortgage payments, and utilities. This loan can be forgiven based on the number of employees retained on payroll, up to 100%. Forgiveness is not available for income above $100,000 per employee on an annual salary basis. The program is retroactive to February 15th in order to help bring workers who may have been laid off back onto payrolls, and loans are available through June 30th of 2020 and payments deferred for 6 months. Applications for the Paycheck Protection Program open tomorrow, April 3rd. Next slide, please. The SBA provides financial assistance in the form of loan guarantees and subsidies to small businesses through the 7A Loan Guarantee Program. The CARES Act increases the maximum 7A loan from $5 million to $10 million and expands eligible uses to include payroll support, employee salaries, mortgage payments, insurance premiums, and other obligations. The Emergency Economic Injury Grants provide an emergency advance of up to $10,000 for practices experiencing an unexpected drop in revenue due to COVID-19. Advances are paid within 3 days of applying for an SBA Economic Injury Disaster Loan, or EIDL, and these advances do not need to be repaid. You do not have to accept an EIDL loan in order to accept the $10,000 grant. Economic injury disaster loans make up a $10 billion program to provide small businesses and practices with working capital loans of up to $2 million to overcome temporary revenue loss due to the pandemic. Next slide, please. The CARES Act also includes an employee retention tax credit for practices that aren't eligible for the Paycheck Protection Program or didn't choose to participate. Any business that's been forced to fully or partially suspend operations or has seen a significant drop in revenue is eligible for a 50% credit of wages paid to furloughed or reduced hour employees. The credit can be claimed against the business's quarterly payroll tax liability and is fully refundable. There are also options to receive advance payments. Next slide, please. The CARES Act allows employers and self-employed individuals to defer payment of their employer's share of the Social Security tax until December 31st. The deferred amounts would be paid over the following 2 years, with half of the amount required to be paid by December 31st of 2021 and the remaining half by December 31st of 2022. The CARES Act also provides an economic impact payment or tax rebate to anyone who filed a tax return this year or last year. Individuals are eligible to receive $1,200, married couples $2,400, and dependents under the age of 17, $500. The rebates phase out at a 5% rate above adjusted gross incomes of $75,000 for single filers and $150,000 for joint filers. The CARES Act also allows for a withdrawal of funds from retirement accounts of up to $100,000 in 2020 without paying any tax penalty. If the physician, spouse, or dependent is diagnosed with SARS-CoV-2 or COVID-19, or experience adverse financial consequences as a result of being quarantined, furloughed, laid off, or having work hours reduced due to the viruses. Next slide, please. Finally, interest on student loans held by the U.S. Department of Education has been waived through September 30th, 2020. Borrowers with commercially or privately held loans, unfortunately, are not eligible. No interest will accrue on these loans for the same time period, and any payments made during this time will be applied to the principal and previously accrued interest. This concludes my overview of the CARES Act, and Jeannie, I'll hand this back to you.
Thank you, Nora. James Kim is our next speaker, and he's not ASA staff, but rather he's from the DC law firm McDermott, Will, and Emery. And James is going to discuss how to access small business loans and some other features of federal aid to help your practices in these difficult times. James?
Thank you very much. I really appreciate the introduction, and I applaud the summary that Nora just provided. What I'm going to go through here are a number of slides that are repetitive for much of it. I will not focus on the sections that were discussed, but rather focus my discussion on the nuances related to the interpretation and application of the definitions in the Payment Protection Program, or what was discussed as the expanded 7A loan program that includes forgiveness. In this case, first of all, I want to thank everyone for joining me on the call. I am in the legal community, but I am first and foremost, I spent 2 years in disaster relief post 9/11 with the 9/11 Fund. I got my degree from Mailman in Columbia in public health policy and epidemiology, and I appreciate the fact of everyone being on the call here. It is absolutely appreciative of what you do on a day-to-day basis. And just to turn to the topic here, the CARES Act here, skipping ahead to the next slide, we're going to be moving over to the actual provisions of the Paycheck Protection Program that were discussed before, right? So expanded 7A loan program, we can skip to the next slide, allows for, as mentioned, a $10 million loan maximum value based upon a historical 12-month average payroll. You take your payroll according to the application, it is for calendar year 2019. You take that payroll over a 12-month period, get the average monthly amount, multiply that by 2.5, and that is your payroll maximum. Over here is listed the description of the organizations and eligible recipients. Most often, practices of this type will be in the small business, fewer than 500 category. I will note, however, One thing to consider that is of much debate in my community is the application of the rule of affiliation. Managed practices, for example, there is a specific rule in certain circumstances that will require you to aggregate your employee headcount. Again, I don't suggest this for the people on the calls after all the case, but there is not just counting the number of people in your entity. The rule is found in Title 13 of the Code of Federal Regulations. It is very specifically applied. Generally speaking, it means where is common control between two different organizations. They are considered affiliated and combined for employee threshold and revenue threshold qualification purposes. In that case, for companies that are in group situations, again, only in those certain organizations, that certain, it is possible that you would have to aggregate that across multiple levels of the organization. I don't think it's probably applicable to the people on the call here for the most part, but I do reference it. If you look at the application form, it states on question 3, you must provide whether or not you have a common ownership or management with another business, and if so, list an addendum A that lists capital A affiliates. That is what is being requested on the form. What other entities are in common interest, common control with the entity being applying for aid, right? So the if it's a practice, for example, that would be the concern. There are a couple exemptions here listed in the statute, not really applicable for the most part here. We can skip ahead to the next slide. We've already discussed briefly the application period, but I will reference some specifics here. Starting April 3rd, 2020, they mean in 2.5 hours. As of midnight, this application goes live to a small number of organizations. There are banks that are refusing to roll this program out immediately and allowing additional time for this to be developed. However, it is starting technically tonight in about 2.5 hours, 2 hours and 37 minutes, according to my clock. There is a list of SBA lenders. However, my understanding is, based on the intelligence that I receive from the various banks, the banks are very much targeting existing lending and banking relationships. Go to your bank first. Ask them if they have a 7A affiliate. If that is the case, you may get an opportunity to apply earlier than others. I am under the understanding that certain banks are refusing to open up applications for the first few days. We'll move to the next slide, please. And we can go one more onto employee. So this is actually a critical definition. If you want to see how to calculate this correctly, it's not an FTE basis. It is all employees, whether full-time, part-time, or other. You count that number, you aggregate that over the average monthly period in terms of numbers for calculation purposes. We'll skip to the next slide. One of the questions that we have received quite a bit on is, what about independent contractors? What about interns, temporary to permanent hire employees? There are specific pieces of guidance on how those are treated by the SBA. Don't make an assumption. The rule applied by the SBA is often different than the rule applied by the IRS or other authorities. You must be cautious. Look to the actual SBA definitions themselves. Unfortunately, because of the interest of time here, it is a fact-specific decision. I can't go through the details there, but I would suggest you make sure to look at the SBA definitions there. One more thing to say, you have to certify that, one, the uncertainty of the economic conditions make the loan request necessary to support ongoing operations. That's a critical piece. You are certifying to a federal government official in the receipt of assistance. The potential penalties for getting this incorrect are very broad. And in fact, the application recites a litany of absolutely terrible statutes, the worst of which, and I will quote from the application itself. It states that I further certify that I have provided in all supporting documentation and forms is true and accurate. I realize that knowingly making a false statement to obtain a guaranteed loan from SBA is punishable under, and I will get to the last one, 18 USA 1014 by imprisonment of not more than 30 years and a fine of not more than $1 million. It is one of the highest standards in the criminal statutes. I do not suggest that there is any concern here. However, it is important to understand that when you sign this application, it is not just the business, it is the 20% or greater owner. And for the majority of people, I would guess, the physicians will have an ownership interest in their practices. They will have to sign on the dotted line personally. Know what you're signing. Read the application carefully. Fill the documents out with a CPA. Go to your professional advisors, get this correct. The value is obvious. They are going to give you 2 months, essentially 8 weeks of salary for your personnel at a near full complement. You will, in addition to that, get up to 25% of loan value, of forgiveness value, which would be 1/3 of your salary payroll amount, inclusive of health benefits, including group health insurance and insurance premiums. You will allow to have 25% dedicated to rent, utility payments, leases, and previously incurred mortgage interest. This is only for items that were previously existing prior to 2/15/20. So if you calculate it correctly, you should have a forgiveness value that covers approximately 2 months worth of salary, plus those additional expenses. Your loan forgiveness should be near to the full value of your loan. If you do this correctly, the obligations are several. The 2 critical ones, well, the 3 critical ones are: first, you may only use funds for permitted purposes. It says and describes them in the law itself and in the application, but they are payroll, including group health insurance and insurance premiums, rent, utility, mortgage interest, and other debt interest that is pre-existing. You may not use it for other purposes. You must only use the loan for those purposes, number 1. Number 2, as mentioned on the forgiveness side, if you think about it, we can skip ahead. There's a couple slides. The differences between eligible expenses and what you get forgiven for are different. The payment of interest on other debt obligations is not included. You will want to be careful and structure how you use those expenses properly. You are also required to average over the period of time in the covered period until June 30th, the number of employees by a head count. It's actually defined as full-time employee head count in the regulation, in the statute. You must recover 100% of that number. You can reduce salaries by up to 75%, and it's a running average over the covered period. As long as you meet those 2 goals, your forgiveness value is 100% and is reduced proportionally based on your failure to meet those 2 standards. The key here is really understanding that you have to meet those obligations, and because it is a running average over the period, you cannot simply not be thoughtful about maximizing that number and ensuring you get the forgiveness value. You should be cautious and remember this. 1, the application is quite simplified but very detailed. There is a lot of information that you are writing in there, and you are certifying to the accuracy of it. You will need to collect 941 payroll tax statements to attach to the form for calendar year 2019. You will need to prepare a list and description of the 20% or greater owners of the organization, prepared to have those owners sign the form as well as the business representative, and get the certifications drafted and looked at carefully. Once that's done, the application is submitted. The processing is very quick. We are expecting money to roll out within days for the first applicants. Weeks will follow before the real bulk of the money will go out. Once that occurs, the issue is that on the back end, in order to obtain the greatest amount of forgiveness, which is in the form of grant, it is actually required for you to send payroll tax receipts, rent receipts, utility statements. There is a much greater documentation requirement on the back end. Getting the loan is easy. Making sure you live up to those requirements is more difficult. Be careful, read the requirements. Make sure you do the calculations right and use your professional advisors to help you through that process. You do it right, you will have 2 months of salary, rent, and utilities paid for by the government. It is a fantastic program, and I do encourage everyone here who is eligible to take serious consideration of application to it. We have on our website at the law firm a coronavirus resource center that has detailed summaries of each of these requirements. We have recorded webinars that are walking you through each of those obligations, and we expect to have one as early as Tuesday of next week that will be targeted towards nonprofit organizations and small businesses. This is not targeted towards our ordinary client base, but towards the greater community, and anyone who is interested is more than welcome to attend. Thank you very much. I'm here to entertain any questions at all.
Thank you, James. I think you got all of our attention on that one. If we weren't paying attention prior to this, we definitely did on that. The penalties are pretty audacious. Our last speaker for tonight is Manny Bonilla. And as many of you know, Manny has been the leading voice for anesthesiology on the Hill for years. And he's here tonight to discuss future federal relief and ASA priorities in the days and the weeks ahead. Manny?
Thank you, Jeannie. I'm going to serve as a bookend to the previous discussion from James Kim and Nora Matus. The situation with these funds is a dynamic situation and that is constantly changing. The CARES Act created some basic structures that are in place. Next slide, please. And will be in place. We're going to take a three-pronged approach moving forward. Number one, looking at the CARES Act, looking at the processes that James has referenced and that Nora have referenced. Are they working for anesthesiologists? Is the federal government getting cash out the door to anesthesiologist practices? Are there changes that ASA needs to seek either at the regulatory level or the legislative level to make the process easier and to make these funds more accessible to our practices? I've noticed on the chat lines there are a number of folks who have indicated they're preparing or have applied for the SBA loans. We would certainly welcome your feedback if that was if that's a reasonable process to go through, and if there are changes that ASA can advocate for to help make it easier for future applicants. Our second prong is going to be preparing for what we expect to be a fourth phase of relief legislation. The CARES Act was the third major package that the government had taken up. We do expect a fourth package to be worked on by Congress. The House of Representatives expected back on April 20th, either to work on the legislation or perhaps even to pass what is being worked on behind the scenes now. One of our primary goals is going to be that $100 billion fund. We do expect that to go quickly. Since hospitals are also in that fund, we don't think $100 billion is sufficient. We will be asking for more dollars to be included in that, and to the degree possible, trying to identify a fund specifically for physician practices. We also want to continue to monitor the small business loan process that was referenced, make sure that there are dollars that continue to be available there. As James mentioned, that money is going to likely go fast. We need to make sure that there are opportunities for anesthesiologists to access those dollars. Also, we're going to look at liability relief. That's an increasingly important issue for many of our members, especially folks who may be moving beyond their scope of usual practice, typically folks doing anesthesia who may be doing critical care. The governor of New York had a very expansive liability immunity that he put in place through an executive order. We want to see if there are options to mirror that in federal action, whether by legislation or action by the administration. But we think it's very important to try to provide those liability protections to our members. We're also going to be looking at what private payers are doing. Certainly the government is ahead of the game and trying to keep up to date on payments for Medicare and Medicaid, but what about commercial payers? Is there an opportunity for Congress to engage in some oversight over the commercial payers to make sure they are appropriately paying for anesthesia and critical care services? And finally, we're going to continue to work with HHS and CMS on enhancing existing Medicare payments. Sharon mentioned some of those opportunities. Obviously, those are not going to make anesthesiologists whole, but we want to continue to seek increases where possible. As part of our formal correspondence with the administration, we did ask for a 20% bump up add-on code for anesthesia and critical care services for COVID patients, because they are no longer typical patients, as those payment rates are typically set at. And that would mirror what the hospitals got. The hospitals got a 20% add on to their COVID-related DRGs, so we thought the same should be applicable to physicians. And then we're also going to continue to look at new payment models. Are there opportunities for us to make anesthesia practices whole or make physicians whole for the work that they're doing? We're certainly hearing a lot about anesthesiologists that are doing a lot of work in hospitals, demonstrating leadership in the critical care space, helping to organize systems within the hospital that aren't necessarily being paid for those services. Or there are opportunities for us to work with the government to have those services paid for. And that's the conclusion of my comments. Thank you very much, and certainly thank all the ASA members for their work out there.
I think now we want to bring back all of our panelists. And Manny, I just want to say, the way this is all progressing, it's just dizzying where we are now versus a month ago. And you're definitely dealing with a moving platform, as are all those that are in practices. It's going to take quite a while to get back to where we were just a month ago or a couple of weeks ago financially. I found in several of the groups that I work with a lot of concern about their financial futures. And so here are just a couple of questions I've encountered. I want to put these questions to the panelists. This is one inquiring minds really want to know. What are some of the strategies that practices have had to maintain clinical and support staff through these financially uncertain times? I'm thinking about how anesthesia practices might be able to ramp up with elective cases once this event passes. You know, the hospital thinks we're like a faucet. You turn it on and you get anesthesia.
It's a great question. As I said before, there is how we're adapting to the event and how we're going to adapt after the event. And it's important that people feel the kind of support and flexibility to get them through this. We are having people use PTO. We're having people use unpaid time off. We're going to be flexible if that's been consumed. And after the event, which we anticipate is a surge of activities, 7 days a week, 24 hours a day, to catch up that backlog of elective cases, we want to engender their goodwill to help support that. That's going to be the use of additional time, additional pay, our facilities being flexible with their support in the economics of it. But we are going to have to work together, because different people will be able to contribute in different ways during this time. Some people have personal demands that will take them out of the loop or that are at higher risk, and so they can't participate at this time. But those people can be banked for the future when they can return to the workforce. Some people were just, and again, fairness and transparency is important, asking everybody to sacrifice proportionately. As I said before, shareholders and partners, the lion's share of the burden falls on them. But that doesn't mean everybody else is not participating in the sacrifice. And as long as they feel that they've been treated fairly, their individual concerns are being listened to, and their employment is being sustained, then they're going to have confidence in the organization and want to be a part of the solution after this event.
you, Steve. I think that one of our previous speakers talked about the compassion and the honesty and transparency with this. Thank you for that. Nora and James, what are the best ways that practices can seek and receive financial help today? What avenues would be best for them to consider? And start with James.
Sure. So I think it's an answer of looking at a lot of, it's a puzzle, right? And Nora outlined a lot of the key levers you'd be looking at in organizing that puzzle. There are unemployment benefits that are available for people who are going to be put on it, if you have to at least, and there are ways, depending on jurisdiction and state rules, to allow for unemployment to be collected when they're furloughed. You can furlough an employee, pay their group health benefits and insurance premiums, and still get unemployment in the right jurisdictions. That lends itself to a certain favorable analysis with regard to payment protection program money. It's a balance. It does not really mean one size fits all. It really depends on your circumstances. You have to look at the pieces that are available. For people who don't look at some of the payroll tax deferrals are a way of advancing capital now, but that bill is due in the future. That is not actually adding funds to you right now. And the other programs out there generally appear to be advances. The program that will actually most effectively put money and capital in your pocket and truthfully to extend the opportunity for salary to be paid to your employees during the next few months is Paycheck Protection Program. The other programs, between EIDL and the other loans, they are absolutely valid as well. They are good ways to access immediate capital. I would be cautious. Everyone sees the EIDL program and says loans of up to $2 million. That is factually true. If you take the average origination value of an EIDL loan by the SBA over the last few years, the average median value is around $20,000 to $50,000. They are not meant to be multi-million-dollar loans. EIDL is just for a brief period of time. That may get you, with a $10,000 emergency grant, to the Paycheck Protection Program. That gets you 2 months forward into the future. The one thing I've heard that I think people are a little mistaken about is this. If you get EIDL money and you apply for the Paycheck Protection Program, you can apply for both, but you only get a salary equal to the Paycheck Protection Program amount. It is my understanding from SBA folks in the lending industry, they are going to refi in the EIDL amounts into your PPP, so you don't get to get extra. It's the same amount, right? The calculation cap is the same in the end. You are not going to look for additional amounts. That's my initial suggestion. There are things you can strategically do for those that with Medicare advance payments and the like, but again, be cautious. Those bills are due in a very short period of time. They are significant payments, but they are not, that's not new money. That is just moving money from the future into your pocket now. It will be due. Just understand that in the reality of this, in this environment, my guess is your services will be well needed. You are essential to everything that we are doing here, and getting by the next few months of what's happening may be what you need to be on your feet and ready to go when the new normal comes back, whatever that might be, right? July 1st is when the Paycheck Protection Program more or less expires. On that day, the worker retention, worker hiring, rehiring requirements will expire. I am aware of many large organizations saying when that money runs out, we are stopping. We are not going to continue to pay employees. We will make hard decisions at that point. Be forthright with your people. Be open with them, have a frank discussion about this, because truthfully, there are a lot of things that can be done to the benefit of them. The answer is these programs are intended to put money in people's pockets, in workers' pockets, not in corporate pockets. And that is important for you to deliver that message to your people, to understand that, look, we're doing everything we can to make this work. Let's be honest, this will allow you to pay people to stay home. If they have valid reasons for doing so, you can continue them on salary with different duties that don't require them to be around. You can pay someone to do less work. It's hard for you to pay someone to not pay someone to do work, right? It goes that way. That would be my suggestion, and thoughtful about that. Try and think about your people. I think the business model is there down the future for you from a demand standpoint. Just, it's important for you to do that. I see a lot of questions on the bottom about 1099 contractors. The answer is SBA typically treats independent contractors as non-employed. But it is a fact and circumstances determination. How the payroll taxes are paid, the structure, all those pieces are relevant. However, on the other hand, owners are fully qualified to be paid under payment protection, but you must you must do a full-time position to get full salary. In order to qualify, you should be spending 40 hours a week with that business. Honestly, I don't think that's much of an issue for many of the practitioners here, but you cannot claim employment if you are not actually working at that practice. You can draw a salary, but counted once, thank you very much, and two, you cannot add it in today. It is historical salary. 2019 calendar year payroll is what they're going to look at. You can't simply make an adjustment today to make that different. Apologize for taking up time, but I think that's an important message to deliver. Thanks.
Thank you, James. And Nora, I'm going to stop you from answering that. We really are running out of time. So at this point, I want to thank you for all the questions. They are being archived, and I think we'll see something that comes out after this podcast concludes in the next several days. So at this point, I'd like to thank everyone for their questions for the panelists here, and I'll turn it back over to Dr. Peterson.
Thank you so much, Jeannie. As we wrap up, ASA would like you to know how COVID-19 has changed your daily life and practice. Share your stories with us and each other. Jot an email to our communications team at pr@asahq.org. As this town hall concludes, you can claim your CME at www.asahq.org/COVID-19 CME 0402. We will have this complete video on demand 24 hours later, but we are going to make all the slides available as soon as staff can get them loaded up tonight. So I want to again thank you for being with us. There will not be a town hall next week because there's several holidays coming up next week. So in conclusion, some of you are in the front lines working really long hours in ICUs, and some of you are furloughed and worried about your livelihood. We don't know what's next regarding the economy. We worry about our families, friends, and colleagues. I want you to know that the ASA leadership and staff are here to support you. Please, please take care of yourselves and support each other. Take some time to exercise and disconnect from the barrage of bad news and recharge. Our nation and our people have been through wars and depressions before. Our upcoming holy days of Easter and Passover are times of celebration after suffering. I know you are suffering now, but we will get through this. There will be a brighter day. Keep the faith, and good night.